program. I am Dr. Sonya Curtis, the Nurse Manager and Quality Manager at the Department of Veteran Affairs for Vision 20. I am located in Crowley, Texas, and I will be your moderator this evening. As healthcare delivery continues to evolve, there is a growing need for CNLs who are instrumental in navigating the delivery of care. As you know, these mastered educated nurses serve at the point of care and are trained to deliver safe, cost-effective, cutting-edge, and high-quality care. For those of you who are looking to develop a CNL program at your facility, this webinar will examine important factors that you should consider as you make your case to decide on starting a program, and also as you make the case to your decision makers and stakeholders. Today, we are joined by 3 seasoned nursing directors who will share their experiences, their lessons learned in launching CNL programs. On our panel today, we have Dr. Maria Thomas. She's a chief nurse. She's currently over research, evidence-based practice, performance improvement, informatics, data. She's also over CNLs and patient safety. Dr. Thomas supports the overarching goals of VA by striving for continuous improvement in healthcare delivery and outcomes for our veterans. Her efforts embody the principles of high reliability organizations, which is focused on quality, safety, and excellence in patient care, ensuring sustained improvement and high standards of care as well. Our second panelist is Dr. Kimberly Hill. She is a manager for continuous process improvement. Dr. Hill is the manager at Dartmouth Medical Center. In her role, she manages the CNL department and the CNL fellowship program, both of which aims to improve patient care and enhance nursing practice and ensure that clinical care delivery is effective and efficient. And our last but not least is Dr. Veronica Rankin. Dr. Rankin works at Atrium Health Carolinas Medical Center in Charlotte, North Carolina. Dr. Rankin serves as a director of nursing in the role of Magnet Program Director, as well as the program administrator over the clinical nurse leaders. Dr. Veronica Rankin has been a nurse for more than 22 years and a certified CNL for more than 14 years. Now, it is time for us to begin our discussion. So I'll ask each panelist to give us a brief overview of their facility and their CNL program, and we will start off with Dr. Rankin.
Hello, everyone. It is my pleasure to be here and to share some takeaways we've learned with our clinical nurse leader program over the years. I currently work for a not-for-profit hospital in Charlotte, North Carolina, as Dr. Curtis shared. We are a level 1 trauma medical center with over 1,000 inpatient beds. We actually are made up of 5 different settings that roll up into one. And so my primary job and role is to serve as the Magnet Program Director. As a certified clinical nurse leader from the bedside, I was moved into being the program coordinator for a few years before being advanced and promoted into this director of nursing role. At the present time, we have 24 certified clinical nurse leaders within our central area, and we have an additional 8 clinical nurse leader interns. We call them interns because we want everyone to know that these individuals are training, they're learning, they're preparing to sit for the board exam, but they are not quite certified at the moment. So we don't want to call them clinical nurse leaders until, of course, they have graduated and passed the certification exam. My facility holds many designations, including Magnet designation. We just completed our 4th our third designation. Actually, we'll be going for our fourth in 2027. We are a niche designation, which stands for Nurses Improving Care for Health System Elders. So we take pride in our geriatric friendly work. And as you all know, CMS is focusing a lot of energy on age friendly health system. And then we are also Plain Tree designated. As I said, with those clinical nurse leader interns, we put a lot of energy and investment into our interns to ensure that they are prepared when they are ready to graduate and sit for that exam, to step out and be the confident clinical nurse leaders that they can be. And so in doing so, we connect them with clinical nurse leaders to serve as their preceptors. Most of the time they are attached with clinical nurse leaders on the same unit within the same patient population. Otherwise, we can definitely connect them with a clinical nurse leader in the same building. I also provide clinical nurse leader certification exam study sessions to ensure that our clinical nurse leader interns feel as confident as possible to sit for that CNL exam. And that is us.
Thank you, Dr. Rankin. Next, we have Miss Dr. Maria Thomas. Oh, did you want to go over those slides for the VA
Yeah.
validated? Yeah, let's go over that
I'll
right
do it
quick.
really quickly. I promise, Dr. Thomas.
Yeah.
So this is just a few examples of validated clinical nurse leader excellence at my facility. Time will not permit to go through all of these, but these were actually examples that were included in our recent magnet document, where in which when we had our magnet site visit in June of 2023, our appraisers were just blown away with what our clinical nurse leaders have done, how they have raised the level of nursing excellence. And so one thing that you will hear me say is the importance of capturing the work. And so to me, these are prime examples of clinical nurse leaders working in various areas with different patient populations on different projects, on different nurse sensitive indicators, and the proof is in the pudding. And so just wanted to share those. Thank you.
All right, Dr. Thomas, go ahead. You have the
All
floor.
right. My name is Dr. Maria Thomas, and Dr. Rankin, wow, that's wonderful. I think that's a lot of work that you guys do. Just to talk a little bit about myself, I am the chief nurse for research, evidence-based practice, process improvements, nursing informatics, data analyst, analytics, CNLs, continuous readiness, and patient safety. So I work for the VA North Texas healthcare system. It's a government or a federal facility. It's a level 1A, and that is based on the complexity of the care we provide for our veterans and the number of unique patients that we see. It's about a 786 bed facility, and I have 12 CNLs and one CNL nurse manager. So the integration of the CNLs in areas, or we have them in med-surg. I have 3-pack CNLs. I have CNLs in telemetry, emergency department, and long-term care, and also spinal cord injury. And that's just a brief overview of VA North Texas Healthcare System CNL program. Thank you. Over to you, Sonya. Dr.
Thank
Curtis.
you. Thank you. All right. Next, can you have next slide, please? Ruby. All right. Now we have Dr. Hill, who will be speaking on her facility. Go ahead, Dr. Hill.
Hi, everyone. Thanks for having me. I'm Dr. Hill. I work at Dartmouth-Hitchcock Medical Center in New Hampshire. We are a 460-bed level 1 trauma academic medical center. Our program has grown a strong leadership model. We now have 12 certified CNLs who provide coverage across inpatient, peri-op, and ambulatory care settings. The breadth allows the CNLs to influence outcomes at multiple transition points and has created consistency of practice. To sustain and expand our model, we have created a CNL fellowship program, which is very similar to what Dr. Rankin has described at her organization. And I want to thank Bob LaPointe and Kelly Walsh, who are on the call, for helping me in the design of that program, along with everyone at my organization. The CNL Fellow role is a bachelor prepared registered nurse that works in the CNL role while completing a full-time master's program. This structure gives them hands-on leadership experience while advancing academically. Upon graduation and certification, the fellows are promoted into a full CNL position. This helped to strengthen our team and expand our leadership throughout the organization. And our model combines both certified CNLs and the fellows who are in training, fostered by mentorship, professional growth, and creates a sustainable pathway that advances practice across our continuum of care.
Okay, now we will go into our first topic of discussion, which is the business case for launching a CNL program. I think we have a polling question. Yes. So, you guys, we have a polling question that are getting ready to come up, and Ruby will share that with us, and I would like for the audience to answer the questions. There we go. Give you guys a couple minutes just to answer the question. So the first question is, how important do you believe a CNL program is for improving patient outcome and care quality in healthcare settings? And then number two, which areas do you think are the most important when building a business case to launch a CNL program? And the third question, you guys, is what is or are the primary drivers for your facility to consider implementing a CNL program? All right. All right, you guys, we're getting ready to wrap it up. If you haven't answered your questions, just all right, Ruby, you want to show us the results of the questions? All right, so stakeholder engagement and communication is number two. Let me go up here to number one. All right. It states that it's very important for us to have a CNL program in the facilities. And then I already stated number two is related to stakeholder engagement and communication. Number three, we had what are the primary drivers? It says organization, vision, and mission alignment. So thank you for sharing those. All right, next slide, we'll go to Dr. Rankin.
Thank you. So in establishing the business case for the clinical nurse leader role, we were very fortunate that our chief nurse at the time actually brought the clinical nurse leader role to our hospital and then basically sold the nursing team on it. She saw this benefit of this role. She had read the research. She had actually started meeting with a local university to get them to bite the bait in providing the track at their university, and then met with stakeholders at our hospital to make sure that we had the funding. And so what she wanted to make sure of was that the clinical nurse leader role was embedded within each unit's hours per patient day. She wanted to do this on purpose simply because she had been in other facilities before where when budget cuts happened, they would look at any roles that were not as close to the bedside, and those were the ones that were at a higher risk for being cut. And so she did not want that to happen. So she wanted to make sure that the clinical nurse leader role was embedded in those unit hours per patient day. And then what she said to our leaders was the return on investing in this role was going to be based on quality indicators. Those nurse sensitive indicators, falls, CAUTIs, CLABSIs, all of that and above, but then also length of stay, readmissions, because she had a true understanding of what the clinical nurse leader role was all about. She then became an instructor at that local facility. She sat for the CNL exam, and I believe that that in itself was what made the launch of our clinical nurse leader program so strong and still sustained to this day. Thank you, Dr. Curtis.
Thank you. It's really important to hear about the hours per patient day to ensure that we keep the CNLs embedded in, and also, looking at strategic planning and putting them in there as well. That's wonderful. Next, we'll have Dr. Thomas.
So for the Dallas VA, I think some of the things Dr. Rankin mentioned initially when the CNL program started was the vision of our Associate Director for Patient Care Services. The executive leadership took it on. We had multiple visits with the local university to see how we can develop a CNL program for the Dallas VA. And here we are today. So I do want to share that the transformational leadership or the executive leadership vision is where it has brought us here today. So definitely looking at it now, it is all aligned with the facility strategic initiatives, and that is to enhance patient care and service delivery, and also looking at our microsystem to look at what kind of transformation can occur within the microsystem, looking at fostering collaboration with the frontline staff, the unit leadership, the staff development specialists, the ancillary team, and also to looking to improve and sustain the nurse-sensitive outcomes, to focus on metrics such as patient falls, pressure ulcers, CAUTI, CLABSI, and fall, looking to optimize our patient care processes, to enhance the care efficiency and patient experiences through streamlined processes, and also to influence the implementation of best practices. Definitely also looking at cost avoidance, also looking to improve nursing sensitive indicators to avoid the cost associated with treating conditions such as hospital-acquired pressure injuries and other urinary tract infection, central line associated bloodstream infections, and also injuries from falls. That's it, back to you. I also wanted to share some tips for large or small facilities. Hospital administrators who have a decision-making authority to create a CNL should look at the organizational needs. That could be by conducting a needs assessment to identify where the CNL role can have the greatest impact. The other one is to definitely align with the strategic goal, as was mentioned earlier, looking at improving patient safety and enhancing the care quality. Securing the leadership buy-in is very important. And as you can see, the case where Dr. Rankin was talking about, and again, in the case of Dallas VA, the leadership buy-in is very important. Engaging them and the key stakeholders in the planning process to secure their buy-in and support for the CNL program, and also to develop clear role descriptions, to have what outlines their responsibilities, the scope of practice, the expected outcomes will provide clarity and also acceptance. Another important one I think we have heard from all the panelists here is invest in education and training. So some kind of a fellowship, which was a start of where we had when we initially started with the CNL program, and also providing ongoing education and training opportunities for CNLs to ensure they're equipped with the latest evidence-based practice and leadership skills. Also to promote interdisciplinary collaboration, fostering a culture of collaboration by encouraging CNLs to work closely with the frontline staff, the unit leadership, and other healthcare professionals. Also using data-driven decisions. So it's very important to have those data dashboards, data analytics also involved and working side by side with the team. And finally is to monitor and evaluate performance. So looking at mechanisms to track the impact of the CNL program and the outcomes thereafter. Thank you. Back to you, Dr. Curtis.
Thank you. And I think that is a great recipe. I call it a recipe, your tips there, to really share with various organizations. So those of you that are in the audience, please take, a note of the tips, because these are the things that we're needing to use to definitely showcase our, or help us showcase our business case. All right, next, Dr. Hill.
Thank you. Our clinical nurse leader program was built to align with our organization's strategic plan. We were aiming to foster continuous learning and a culture of data-driven decision-making. We invested in creating a team of evidence-based practice experts who are directly influencing quality, safety, and patient outcomes. To ensure success, we designed an intentional onboarding plan that introduced core leadership competencies early on to help prepare the CNLs and the fellows for impact from the very beginning. Importantly to note is our fellowship positions were created without adding any new FTEs. We were leveraging existing unfilled roles. The efficiency paired with strong support from our senior leaders demonstrates the organizational commitment to our program. The business case, I believe, is further reinforced by measurable results. Previous CNLs throughout the organization before the program had reductions in hospital-acquired conditions with associated cost avoidance, improved staff engagement, and standardized workflows that made care safer and more reliable. The CNL program can help advance strategic priorities as well as build internal capacity and demonstrate measurable return on investment.
All right, now we're going to jump into the impact of the CNL program within the facilities. We have another polling question, engaging CNLs effectively. Ruby, you want to pull the polling questions up? All right, you should be able to see the polling questions at this time. First question is, how confident are you in your facility's ability to effectively engage CNLs in leadership roles? Second question is, which strategies do you think is most effective for integrating CNLs into the existing healthcare teams? And then number 3, what is or are the biggest barrier to effectively engaging CNLs into your facility? All right, you want to close those out, Ruby? So for number 1, it looks like it's 30% that say that they're confident in their facilities' ability to engage the CNLs. And then number 2, 78% is pretty large with engaging clear roles and definitions and expectations is most effective for integrating the CNLs into the healthcare team. And then number 2, we have 61%, actually we have a tie of 61% for lack of understanding of the CNL role and inefficient support from administration, which is one of the 2 biggest barriers to effectively engaging CNLs into the facility. All right. So Dr. Rankin, you want to start us off with this discussion?
I sure will. The poll we don't have time for me to get all into it, but I have so much that I want to say on that, but I will stick to the script. I will say 47% of those on the call saying that they feel like CNLs are being engaged in leadership opportunities. I think that there's something that we can do about that. And maybe there are times that it's out of our locus of control, but I think that there are times that we can. And we'll get more onto that in this webinar in a few minutes. But the impact, I would say, that our clinical nurse leader has shown and demonstrated. Now, I will tell you, our program has been alive since 2010. So that's 15 years. We didn't just launch 2 days ago. Okay, so we have some years behind us. In the beginning, it was climbing uphill. It was constantly telling everyone what we are, what we're supposed to be doing, telling ourselves what we were trying to do, what we were supposed to be doing at the clinical setting, creating that elevator speech to where we were so ready to say it that we could say it quickly and confidently instead of and that kind of deal. And so I think that helped those of us who were in this work from the very beginning become that much stronger in providing that case of why you need a clinical nurse leader at this hospital. Beyond just the quality outcomes, which is what we definitely have a fingerprint on, We also wanted to show others that, we actually look at research and bring it to the bedside. We engage nurses. We increase professional governance, also known as shared governance. We have a thumbprint on helping my hospital get successfully magnet redesignated and in leading niche designation. Our current geriatric work is led by a gerontology clinical nurse leader who's doing phenomenal work. We also have a diabetes population clinical nurse leader. This is all because of our previous chief nurse, Dr. Rob Rose, looking at those areas, those populations that are oftentimes overlooked. And then also we said beyond that, beyond evidence-based practice and research and all of those things, guess what? We're also going to impact nursing degree and certification. We're going to impact nursing turnover, because when nurses feel like their voice is heard, when nurses feel supported, when they know that someone is there to help their day go along easier, to make their work more efficient and more effective, you're going to have higher nurse satisfaction scores. Also, in increasing nursing publications, we have a lot of clinical nurse leaders at my hospitals who are published. But not only are they published, they pulled nurses along with them and said, you know what, let's work on this together. I'm going to help you, and then we're going to work on this to get it published and put in the literature. And then you're going to go to a conference and present this work. That alone has had a great impact on our nursing turnover retention rates. And then also, of course, the population-specific outcome work that has been ongoing since our Dr. Rob Rose came in 2018. He switched us from a 12-bed microsystem to a population-based focus of clinical nurse leader practice. And that alone just rejuvenated the work that the clinical nurse leaders are doing. I would say that if you can present the case and tell someone, just like anyone else, why I am needed, why my role is needed in a facility, this is what I'm going to bring, this is the return on investing in my role, that's where we build that case, and that's where we can engage clinical nurse leaders into the leadership work that's needed in the hospital. Back to you, Dr. Curtis.
Thank you. That was some really good information. I really appreciate the part about the publishing nurses publishing, because we need a little bit more of that. I'm going to go ahead and pass the podium on over to Dr. Thomas so she can tell us about the CNLs working effectively.
Thank you. And I want to say that ours is still maybe about 4.5 years of our CNL program being in effect. We did have some turnover, but I'll say every year we bring it to the facility, the outcomes, the indicators, the practice, safety, and all of these that we excel in. So they've created, we are part of the solution to reduce falls, fall rate, fall with injury. We've always seen a downward trend since the implementation of the CNL into our microsystem. We've also seen an improvement in nursing practice and nurse-sensitive indicators, most specifically CARDI, CLABSI, the pressure ulcers, all the infection rates, and the fall prevention. We have an enhanced awareness of evidence-based practices, marked improvement in the awareness among staff, also driven by the CNLs focused on integrating current research findings into practice. Even the role of in the bedside, talking about the difference between EBP research and QI, and just creating that awareness and being part of those EBP trainings have created a lot of that awareness. There's increased completion of PI projects. The completion of the rate of the PI projects has notably increased, also resulting in more systematic and sustained quality improvements within the facility. They also have additional collaborative roles that I would say we have frequent requests for CNLs to be part of any facility-led initiatives, RCAs, outpatient services, there's risk management, they request for peer reviews. Our CNLs are the ones that do the first level peer reviews for all cases for nursing. They also play a very critical role in patient care and safety, Joint Commission accreditation reviews. They are an integral part of the stand down. Reduction in fall rates have been very integral. They've brought intangible improvement in nursing practice and also increasing the nursing satisfaction. That's it. Back to you, Dr. Curtis.
And we'll move right into with you, Dr. Hill.
Thank you. We have had CNLs at our organization before, but this is our first big attempt at having a CNL program. So we, about last June, started to really be thinking about this. Our CNL fellows began in January. So despite our being a newer program, we have already had some meaningful improvements in our patient care across the inpatient, peri-op, and ambulatory care settings. So because we are bringing real-time quality improvement to the front lines, we're leading harm reduction initiatives by strengthening communication and creating standardized processes. Our fellows have played a vital role in this already by contributing to infection prevention efforts and advancing the culture of safety in spaces where it did not have a consistent person doing that before. Together, our team has achieved measurable improvements by streamlining transfer workflows that reduce delays in care, greater accuracy and medication administration through tube feed scanning, and prevention of adverse events such as pressure injuries and falls. Beyond that, our program has supported the implementation of hand hygiene observations, the development of clinical pathways for pediatric chemotherapy, and enhancing staff training and vascular access skills for specialized care areas. I think I have one after this. Thank you. Just some key takeaways for the high impact of the role in our health system. With the right structure and strong mentorship, the alignment of the organizational priorities, CNLs consistently can deliver measurable returns from cost avoidance and improved regulatory readiness to a stronger, more engaged workforce. Investing in CNLs is building leaders. The pipeline develops skilled clinicians who can lead change at the microsystem level while advancing system-wide goals. I think most importantly, the CNL role strengthens our collective ability to provide safe, reliable, patient-centered care. It's a model that demonstrates value by reliably improving safety and outcomes. I'll give it back to you, Dr. Curtis.
Thank you. Now we will move into potential challenges in launching a CNL program. You want to go ahead and pull up our program challenges poll, Ruby? All right, audience. We have another polling, three more polling questions. All right, they're on your screen. If you're ready to go through them, I will read the actual question for you. What do you see as the biggest challenge in launching the CNL program? Number two, how prepared is your facility to address potential challenges associated with launching a CNL program? So this time we only have two questions. I said three, but it's only two. All right, I'll give you guys a little time there. Three more seconds. All right, Ruby, you can close it out. All right, so Dr. Rankin, you want to oh, I guess I need to go over the polling questions. I'm sorry. So for the first one, you guys, as you can see, the 61% we have with the biggest challenges buy-in from the staff and the administration and the C-suite leaders. And then number two, seeing how prepared your facility is to address these challenges. As you can see, it says neutral. Neutral falls with the larger percentage, but followed by that, we do have less prepared and prepared. That is a tie. So, all right. So we should be able to give you some good information on how to combat those challenges or, what things we can do. So we'll have Dr. Rankin start us off.
Absolutely. I will say that we were blessed at Carolinas Medical Center, as I said, with our original chief nurse, Dr. Grace Sotomayor, who basically brought the clinical nurse leader role to my hospital. We were also blessed with having an amazing AVP at the time, Dr. Tina Rallier, which I don't know if she's on or not, but she and Grace partnered together and they were in the trenches with us clinical nurse leaders. They were encouraging us. They were meeting with the leaders, basically telling them the reason for why this role is absolutely essential. And so I think that, of course, we'll get more into that, but I think having that leadership buy-in is extremely important, and it can also be a very, very hard challenge to overcome. So having, of course, the buy-in from the clinical nurses, other supportive nursing roles like clinical nurse specialists, nurse educators, and even nurse managers, ADPs, and all of them is an important task. But I feel like if you have upper level, nurse executive level support in the role, they will help in turning the tide. Additionally, defining the role and its impact in healthcare can be a challenge, especially for this newly either about to be certified or still in school kind of clinical nurse leader intern who's kind of like, I'm green behind the ears. I don't even know what I'm supposed to be doing right now. It can be a challenge to be able to provide that definition and have that confidence at the bedside. I will say there are strength in numbers. So as our program continues to grow, we became more and more confident as a group that, you know what, if I don't know the answer, I got a Dr. Sonya Curtis that I can reach out to. I have a Dr. Maria Thomas I can reach out to, and we are stronger once we pull in together. And so the spread of the role, creating that CNL identity, all of those were challenges. Ongoing challenges were continuing to.
Hold on a minute, just a minute, Dr. Rankin. We have a hot mic. It looks like someone named Heather. Can you please mute your mic? Or Ruby, can you please mute the participant? Thank you so much.
All right. Ongoing challenges that we continue to face and deal with is, of course, overutilage of the role. As you can imagine, once our hospital got a real good taste of the clinical nurse leader role and what it can do, everyone wanted clinical nurse leaders on every single project, on every single unit, on every, I mean, the ask was definitely there. And so sometimes teaching and working on saying no, and nope, that's not within our focus, that's not within our strategic plan focus that has been given to the clinical nurse leaders. Sometimes that's a hard conversation to have. But even still, just serving as that consultant, I think, is a way in which we can keep others bought into the role. Of course, the accountability of the team, and by team, I mean those clinical nurses at the bedside. If there is an initiative that's being implemented on the unit, sometimes we have nurses at the bedside that really, really need to be held accountable for doing those things that we as a group decided we're going to do to push this effort forward. Singling out CNL dependent impact to isolate the return on investment in the CNL role, that can be hard. So when you have CNLs working, for example, we did a falls reduction work between our CNL team, and we saw such a humongous drastic drop in falls. We were so excited, and then we got into meetings and the team was given all of the credit. And at the same time, I don't want to sound some kind of way in saying that, we want to give the team their credit, but at the same time it was like, okay, but we need at some point to hear that the clinical nurse leaders were the ones driving this. And when you look at those CNL units that have the drastic reduction in falls and those units that don't have CNLs and their falls haven't done anything, that is the proof in pudding. And to me, that is where my job comes in. I will get on that microphone and in every single meeting point out, oh, wait, so is it just the CNL units where those falls? Oh, okay. Just wanted to make sure that we were all aware that the CNL units are the ones that had achieved that reduction in falls. So just making sure that, you know, that realization is there for everyone. And then, of course, creating a case to increase CNL pay is things that I'm working on right now, because nationally, there really isn't a great comparison that I can say why CNLs need to get more money than what we're currently getting. And that's because we need more growth of the CNL role. And so, of course, that is an ongoing challenge, but definitely one that I'm still up on top of. Thank you.
All right. Before we move over to Dr. Thomas, we do have a couple questions in the chat, and I will read them if one of the panelists would want to answer them. So, do your CNLs have the CNL job title? And if so, how do you conduct market adjustments? Who would like to take that question?
I can take that. We do have a CNL job code, job title for our clinical nurse leaders. When they're clinical nurse leader interns, they are in the clinical nurse role in job code. But when they become certified and graduate, then they move into that CNL job code. Those market adjustments right now, that is what the battle is of looking at how we're currently being paid, what the national rate is, and trying to build that case for why I believe it should be more than it currently is. But yes, Dr. Thomas, Dr. Hill, do you want to respond on that?
Yeah, so we don't have a separate, we do have a separate CNL job title, but it's all clumped together. We are all, like, my area is fully under education. So we don't have any separation. We are all seen as education in the service of, in the nursing service, but CNLs have a separate title and position. So we don't do any market adjustments. Yeah, so back to you.
I think similarly, our CNLs have to be certified to be in the CNL role and called CNLs. They have their own job code. Our CNL fellows are called fellows because they are not certified. So anyone who's not certified can't say that they're a CNL. And they have their own distinct job code that's separate from a clinical nurse.
We also
Okay.
have, sorry, I meant to add this. We do have a pay range for our clinical nurse leader job code that is equivalent to a clinical nurse that's been on the clinical ladder twice, who has advanced on that clinical ladder twice. But again, that's what I'm still working on, trying to move that range higher than what it currently is, because I feel like it should be higher.
All right, our next question is, do you have a continuous development program specific to the CNL role? And if so, can you share a bit about that? Dr. Hill, you want to take that?
Yeah, our restructuring just created a department of continuous process improvement. So that is where the CNL group is under. It's a lot of clinical nurse leaders. The clinical nurse leaders, I'm going to touch upon the next question. They report to me, also a clinical nurse leader, as a manager. So I am not in a microsystem. I am the manager of the team who reports to the director of continuous process improvement, who reports to a vice president. So that's kind of our reporting structure. They don't report to the unit managers at our organization. They are a partner to the unit nurse manager, and they are kind of a triad in leadership with the unit nurse manager, the partner, and then the educator. And as far as a continuous development program, I think that's what we're working on right now. We've had a lot of emphasis on development of the clinical nurse leader fellow position right now. But amongst our team, we work with a Lean Six Sigma black belt, and we're working on professional development really for the whole team.
All right, we will get to the rest of the questions. We want to move on to the time. So, Dr. Thomas, you want to go ahead?
Yeah, so initial program challenges, I think I want to say that we did have some resistance from leadership and other teams. Initially not wanting to embrace the CNL roles again because of adding a CNL role to probably also nursing education and case management and other roles, and not understanding what it really means. So having to provide the role justification. Also, I think I can probably also see some resistance from nurse managers who are not master's prepared, because the CNLs are certified graduate level. So there is a little bit of acceptance or between the nurse manager and the CNLs. The CNLs are very strong. They know what they're doing. So it might come across as being really strong to the nurse managers. So there's also the role boundary issues. So some of them go beyond their boundaries because of the way their roles are set, having to get permissions or being inclusive of the stakeholders. There is sometimes issues with those defined roles, which leads to confusion and overlap in the responsibilities. Also, communication is one of the barriers. I think continuous awareness of what their roles and responsibilities are is probably one of the challenges that we have to deal with. Again, like I said, ongoing challenges are, again, leadership resistance. We still have some units and areas that are not open to having CNLs because of the reporting structure, which is they don't report to the nurse managers or the chiefs of those areas. They report to the nurse manager who reports to me. So there's some ongoing challenges with the leadership there, and also the lack of resistance. So I think, again, targeted education, clear role delineation, and awareness should be a continuing opportunity. Thank you. Back to you, Dr. Curtis.
And you can go ahead, Dr. Hill.
Thank you. I don't want to elaborate too much. I think Dr. Rankin spoke really well to this before. As we are a newer team, I think right now we're really focusing on our role clarity throughout the organization, really establishing ourselves as leaders with a level of authority to enact change, and then an emphasis on our elevator speech to highlight what we are able to do with advanced education certification and our unique role contributions at this point.
All right. I'm going to go ahead and read one of the questions before we jump into the recruitment strategies. At your organization as a CNL, we do have a specific job title and report through evidence-based programs that is under a director who reports to the associate chief nursing officer. It's been a benefit to not report to the unit and report to the director level. I guess there wasn't really a question; it was a statement, but that sounds more like what you have, Dr. Thomas, and you
That's correct.
as well as Dr. Hill. All right, so let's jump into CNL recruiting strategies. All right, we're going to have another polling real quick. So participants, are you ready? Oh, here we go. First question. What is your facility's most effective recruiting strategy for attracting certified CNLs to your facility? Question 2. How challenging is it for your facility to find and recruit certified CNLs? And number 3, what resources does your facility need to increase recruitment of certified CNLs? Give you 2 more seconds here. We're going to close the polling. All right, Ruby, can you go ahead and close the polling, please? And we'll review real quickly. So for the first one, it looks like it's 38% for providing opportunities for career advancement is the most effective recruiting strategy. And then looking at how challenging it is for the facilities for recruitment, it looks like 38% is challenging and 29%, which follows, is very challenging. And then resources, does a facility need to increase recruitment? And we have here with 33% increased budget for recruitment efforts, and then followed by 29% enhanced partnership with the nursing schools, and 25% with implementation of a target recruitment campaign. So, all right, Dr. Rankin, you want to go ahead and jump in and tell us about recruitment strategies?
Absolutely. So our recruitment strategy, of course, is an internal type strategy. We have started posting externally for clinical nurse leader job positions, but what I love is that our leadership, our executive leadership team, really wants to grow within our hospital, within our system, and then, of course, open it up to those outside of the system. And so I think the best way in which we can recruit potential CNLs or individuals looking to go back to school and they're deciding what they're going to go back to school in is to lead by example, to show them what a clinical nurse leader does. And by being able to do that, that is the best way in which we've been able to recruit incoming CNLs as we've had CNLs go off into other parts of the vineyard. Another recruitment strategy that I will add in is that we look for ways to grow our clinical nurse leaders into next positions. So it's succession planning. So if we have CNLs interested in becoming a nurse manager or becoming a nurse practitioner, we're not trying to hold them into that clinical nurse leader role. If anything, I'm always quick to say, I will give you a reference letter. Do you want me to connect you with the CNL who's done what you're trying to do so that maybe you can reach out and see what are learnings you can work on right now to make yourself more marketable in stepping into that new position? I will say as well, a CNL chapter. I don't know if Jocelyn White, who is our current CNL chapter, Carolina's chapter president, is on, but she has taken our chapter and has, oh my gosh, injected steroids and multivitamins and IV fluids and everything, all of the above into our chapter to where we're about to launch something that is just so much even better than what past presidents have been able to do even throughout a pandemic. And so I think that new set of eyes, engaging clinical nurse leaders into the work, partnering with our local colleges. We have very engaged faculty members in the CNL program like Dr. Larise, schoolmeisters, and others who have been a part of our chapter since day one, making sure that we have that engagement from those faculty members, and that partnership I would say is very, very important. So those recruitment activities, anytime there's a CNL summit, making sure we have some kind of flyers out there for anyone who is interested. I love even just stepping outside of my hospital. UVA, I don't know if someone is on from the University of Virginia, but I've received emails where it's actually commercials where they're trying to recruit me as a CNL to come to UVA. And I'm just like, oh my gosh, I'm just so impressed by this. I think those are all activities and things we should explore. I don't know how they get the emails, but UVA is just doing it. I'm very proud of them. And then, like I said, those external job postings. And then the chapters, this clinical nurse leader, executive team, making sure that individuals within the hospital know that this is a growth opportunity. There's a lot expected of the role, but with stepping into this role, you're stepping into a club of individuals who are just those change agents. So I think leading by example is one of the best ways in which we've been able to recruit for the role and partnering with the local schools.
Thank you, Dr. Rankin. Okay, Dr. Thomas.
So our recruitment strategy is we actively recruit CNLs from local hospitals or healthcare facilities. There's an existing supply of practicing CNLs in the local area. One of the biggest hospitals that hire the CNLs, they dissolved their program, so we were able to hire the best, and we still have people reaching out to us to find when we will have some opportunities available to them. We do also have an internal scholarship program that provides financial support for candidates pursuing CNLs, and we are able to hire them once they pass their board exams. So these are some strategies, and then we post them internally first because we do have CNLs in areas that are not in the CNL role, so we do post it internally before it's posted outside. Back to you,
Dr. Hill.
Similarly, we recruit through professional development from within. We have our new CNL fellowship program, which I talked about earlier, and then we're seeking to expand into our high need microsystems next that will create a wider impact. For succession planning, we have a safety champion program that's supported by our unit nurse managers and our clinical nurse leaders that are in the microsystems. That provides protected time for clinical nurses to lead quality and safety efforts specific to the unit needs. So it's just another effort to succession plan to see if anybody is interested in that kind of work.
All right, thank you. So now we're going to jump into CNL pay and incentives. Dr. Rankin, you want to take us right on into that?
Absolutely. We've kind of touched on it a little bit already, but like I said before, our CNLs have their own pay range. Of course, it is, of course, higher than what a new grad coming in or a clinical nurse who's not been on the clinical ladder should be at. Clinical nurse leaders are paid at an hourly rate. It's not salaried because we wanted to make sure that as CNLs are working overtime, that they are able to get that extra incentive. Also, clinical nurse leaders can pick up extra shifts in staffing if they want, or what have you. At one point, it was kind of like, no, you can't be a clinical nurse leader and then dip out and pick up an extra shift as a clinical nurse at the bedside, but that's been changed, of course, since the pandemic. With the CNL pay, only certified clinical nurse leaders can get that pay range. CNL interns will get paid what they're paid as a clinical nurse from the bedside until they become certified and pass the CNL exam. Other incentives we have regarding going back and getting certified, going back to school, and all of that is educational assistance benefits that we have. Our previous chief nurse worked so hard to increase what that amount of money is to make it more that we could have for continuing education, and then a good amount that's separate for degree advancement as well. And so there's a couple different ways in which CNLs can work on. And also, too, I'll add this, we have a lot of our CNLs that work as faculty members in ABSN programs and graduate nursing programs as their way of giving back. Additionally, when CNLs work as preceptors, there's a preceptor incentive as well that they can get. Thank you.
Dr. Thomas and Dr. Hill, just want to let you guys know real quickly, we're getting down to our time, but if you want to go ahead, thank you.
Okay. So we conduct a compensation assessment every year and compare our pay rates with national and statewide compensation benchmarks for CNLs. And our pay rate is higher or similar to what is offered to the CNLs on the outside. So that's why we don't have anything special. We also have a scholarship program for nurses that pursue the CNL certification. So it is the same pay as a regular nurse because it's on the higher side. To you, Dr. Hill.
We are CNLs and CNL fellows both salary as a 1.0 FTE. They both have separate pay ranges. The CNLs are very similar to the unit nurse managers, and the CNL fellows are similar to a unit nurse supervisor. And all certifications at our organization are recognized publicly with an RNC badge for people to see, with an annual stipend and certification reimbursement.
All right, now we're going to jump into final thoughts. Before we jump into the final thoughts, I would like for each audience member or participant to drop into the chat what are your final thoughts as well about this presentation and webinar. Go ahead, Dr. Rankin.
Really quickly, because I know we're pressed for time, to me, the CNL program success depends on nurse executive buy-in and leadership. Having a plan in which the CNL program is safeguarded from typical budget cuts, I think is very important. Aligning with clinical nurse leader practice with other supportive roles is very important, such as, how's the CNL work with the CNS, work with the educator and all that, so there's not competition there. Succession planning to make sure that when CNLs want to expire into other roles, they're able to. Of course, CNL chapter that I mentioned before, and then publication and dissemination. If we can go to the next slide. Our CNLs have worked really hard over the last couple of years, even before then, to get publications out. And so these are just a few examples of where we're focusing on getting that information out, sharing it broadly, making sure that the work of the CNL is captured in the literature, it's captured in research. And you can go on to the next slide as well. This next slide shows a collaboration publication that I did with Dr. Kimberly Pate, who works at my hospital, who is a CNS. And we wanted to show how CNSs and CNLs can work very, very well together and really turn the tide in any kind of initiative that we're focusing on. And so I think showing that collaboration is very, very important. Thank you.
So final thoughts, I do want to thank CNC for allowing me to be a panelist, and Dr. Curtis for being the facilitator, and everyone on the CNC team. I want to say launching a CNL program for us, want to say it's a multifaceted approach to improving patient care and operational efficiency, and also financial performance. Employers, healthcare executives, and hospital administrators should recognize the value of CNLs bring to the frontline staff that drives quality improvements and achieves sustainable positive outcomes across the healthcare setting. So I cannot say enough, because I am seeing these outcomes and throughout the service and facility. So that's my final. Thank you.
I would say for final thoughts, structure is very important. It matters for both onboarding, access to data, and supporting real-time quality work. Mentorship is very important throughout our program, and I think ongoing. So pairing new CNLs with experienced CNLs, as well as fellows with experienced leaders, it helps to build confidence amongst the group, and it can help accelerate impact and support retention within the program. And then measurement really drives sustainability. So using the data-driven outcomes to track outcomes for harm reduction, process improvement, and staff engagement.
Well, thank you so much, Dr. Hill, and I would like to thank everyone for attending our Elevating Patient Care Through an Effective CNL program, and thank you to all the panelists. The information was so valuable. As you can please review the chat right now. You can see how all of the information has really helped those, and I loved some of the input people were giving about how we really need to be working with those leaders in the C-suite and getting buy-in from everybody in the team. So again, I want to give thanks to Ms. Moore. I also want to give thanks to Ms. Gardner, who's the director at CNC, and also to Ruby Carr as well. We appreciate all that you've done with us to get this showcased, and everyone have a fabulous evening and day. Goodbye.
Good night. Thank you, guys.
Yes, thank you.